any kind of values, like potassium, like if you look at a full ABG, you get tons of different values. So there are, your blood makeup, whether it's on the arterial side or the venous side of your body, still has the same components in it. They're just in a different range, right? So the only difference is which one you should be using to interpret your acid-base disorder. So when you look at some more complex ways of really truly diagnosing acid-base disorders, you actually can use that bicarb value that's on your ABG in a more complex equation. You can look at the degree, kind of what I was talking about in the beginning, you can look at the degree of compensatory that you have occurring. So like how far away you are from these different values can tell you kind of where your patient is at in terms of compensation, or if they're not really compensating. But for what I want you guys to look at, just focus on the simple ways to diagnose things. When you're doing, when you're calculating an anion gap, or you're looking at most acid-based stuff, when you're looking at that bicarb, because it's more of an indicator of what your kidneys are doing, look at that value that's on the venous side of your blood, not on the arterial side.
Thank you.
Yes. Okay. All right, good.
Will we ever get a bicarb measurement from the venous side, or just do CO2 when we're evaluating this?
So it's just the CO2, so the CO2 on the venous side is indicative of what your plasma bicarbonate level would be on the venous side. So, because bicarbonate is not really stable in your body, it pretty readily dissociates, we use that CO2 that is found on the venous chemistry panel as a surrogate marker of what your bicarbonate level truly is in your body.
CO2 have the same value as CO3, like the same line, 22 to 26?
I think you used 22 to 26.
So that's still within range.
Dr. Brandon? Just to clarify, so is there not any compensatory mechanism going on in that very first patient?
Yes. So there's not really any compensatory mechanism. I mean, even if you look at that bicarb value that's on the ABG, it's pretty close. So, yeah, there's no compensatory mechanism that's going on in that patient yet.
Okay, thank you.
You're welcome.
At the hospital, I've worked with a pharmacist named Brandy for. I've worked with Brandy for a solid 6 months, and she called me real for the first 4 months, and then Brandy only like 2 months, and she was like, she pronounced my name and started calling me Riley. And I was like, nope, you just went backwards. I'll get this right for so long. Oh, no. I get pregnant a lot. Brightness skin? I've never, guys, do you want to know my allergy is my favorite thing ever? Wait, I graduated high school, I graduated from so I have so many different ceremonies or honor ceremonies. Nobody's ever said my name right until I was older. And he pronounced all 3 names, like my first, middle, and last name, all of them correct. Yeah, when I graduated from nursery, I wrote out how to pronounce my first 2 names because I was like, this is what I'm going to stop. So she said Brielle, Stefania, Scoot. I'm going to scoot on out of here, bye.
Hey, I knew that. So I was like, but I don't.
You do Scoot that way? Probably. Oh, but it's okay. I am a person.
Dr. Brandon. It's me right over here, and so when I'm calculating the excess NI gap, do I use the bicarb level or would I use the CO2 level for the venous CO2?
So for the anion gap, okay, all right. So I went back and I got ahead of myself a little bit and was thinking about all the questions and stuff we were just talking about. So for steps 1 through 3, when we're looking at those values, so look at all of that does come from the arterial blood gas. You guys were right in the beginning. I was getting ahead of myself and thinking about the steps of 4, 5, and 6. So, and I know this is super confusing, so I'm going to take a second because I even confused myself thinking about some of the later cases. So in steps 1, 2, and 3, you're only looking at basically you're looking for basically what your primary problem may be. So look at those values are from the arterial side. So those normal ranges, everything that you guys are talking about, that's all the normal values from the arterial side. So use those values, the PCO2 and the HCO3 that are found from the APG for steps 1, 2, and 3. Okay? Because even though your kidneys do take a little bit longer to kick in, your lungs are really sensitive to that, and you can start to see those changes even slightly in the arterial side. So when you're looking at steps 5 and 6, when you're really looking at those who are looking at primary metabolic disorders. So you are going to always use that CO2, the carbon dioxide level that you see from the venous chemistry panel from your lab. Does that make sense? Like if you got morning lab from somebody from the venous side. So from 5 and 6, when you're calculating your anion gap or your excess anion gap, you're going to use that CO2 carbon dioxide value that's found from the chemistry panel. That's a venous sample. Does that make more sense?
No.
I'm sorry. I know
Just you had it right the first time?
Yes, the original thing that we talked about. So 1 through 3, so when you're looking at those things in the beginning, look at that HCO3 value that's found from the arterial side. And then when you're doing 5 and 6, and you're looking at your anion gap, looking for basically a primary metabolic disturbance that may be happening, you're going to look at that from your chemistry values, so that carbon dioxide that's found from your venous sample that you get from like your morning lab draw or any lab draw that you guys are normally used to seeing. Yes. Yeah. So for number 1, if we go back to that, it was right from the beginning. So looking at step 3, that value of 21 that came from your ABG was less than 22, so you do kind of have like a little bit of a metabolic acidosis that's starting, because it's just less than 22. So you have some slight compensation that's there, even though not very much. Is that good? Okay. All right, then we'll be in good shape for the rest of it.
still.
Huh?
Excess is just total minus the loan plus the byproduct.
No, it's just like what you originally had was right. It's 20. So 1 3 movies are treated. Yes. Yes.
So 21.
Yes. What we had the first time was 20. Oh, yeah. So yes.
Unless all 3 lines of worship and the pockets.
Oh, the elevated that we're in for.
So number 3
Yes.
or when you compare, you don't use that same number. So up to 4 would I wear?
Can you repeat that? Oh, you're saying yeah. Okay. Well, shoot.
Underlying non-metabolic acidosis.
Okay, how do you guys feel about starting to look at cases 2, 3, and 4? Good. Couple more minutes? Okay. Okay.
It's like getting high. Oh, you can give it.
We could have been out of here, but she had to give us 8 cases.
Yeah. I don't know. She put literature supports. I don't know if she means
Oh,
do this.
yeah.
I don't know what she means by just don't do that. Or do this.
What about just giving bicarbonate?
You're not. You're supposed to stop. Yeah. You're supposed to like stop the.
Oh, that is the offense.
Yeah. All of them. Well, yeah. Well, not that. I don't know. Stop.
Why are there so many?
We talked like stop. We only not over 9, right? Like, it can decrease, but as long as it's not over 9 yet, you don't have to use it.
No, they're already there.
That's
What? I did not.
Okay, all right, let's start looking at some of these cases, and if we're not quite through, we can go through some of them together. Hopefully we can all look at it and be together. So in case 2, we've got a previously healthy 53-year-old male that's presenting to your ER. So in Savannah, can group number 25, can you do steps 1 through 3?
Alright, so the pH was 756, which is alkalotic. The PCO2 was 52, so it's acidic. The bicarb was 40, which is alkaline.
Okay, good. All right, and then group number 8, can you do 4, 5, and 6?
So pH and CO2 both indicate alkalosis. Patient is experiencing metabolic alkalosis with compensatory respiratory acidosis. And we calculated the anion gap to be 9, and we didn't need to calculate the excess.
Okay, all right, good. And then can group number 9, can you describe the disturbance, what you think the cause is, and what treatment you would recommend?
So we said that it indicated metabolic alkalosis. The underlying cause for the respiratory acidosis is the compensatory change. We said the most likely cause was due to their severe vomiting, and we recommended chloride supplementation, either sodium or potassium chloride, IV or oral, and treat the vomiting.
Okay, all right, good. So does everyone agree with that? So we have in step 1, so pH, we've got the value of 7.56 indicated in alkalosis. Your PCO2 was 52, and that's greater than 45, right? So that's a respiratory acidosis. Your bicarb from the ABG was 40, which is greater than 26, and that's a metabolic alkalosis. So then when you're looking at step 4, your bicarb was moving in the same direction as your pH. They were both moving in an alkalotic way, and your PCO2 was moving in an opposite direction. So I agree that there was no anion gaps in the normal range, and so you didn't need to do number 6. So again, so exactly right. So I would describe this as a primary metabolic alkalosis with a respiratory acidosis compensation, most likely from vomiting, and you also know, in addition to what you get from the clinical picture, you have a non-urinary chloride loss because you see your urine chloride is less than 10. So I agree. So you either can treat, you can do either one of the 2 or both. You can treat the patient's nausea and vomiting, and then also consider giving them chloride supplementation. And you can see the chloride value also on the chemistry panel is low. So you can either give sodium or probably sodium and maybe not so much potassium because your potassium is a little bit on the high normal side. Everyone good? Yes.
What would you recommend using for the chloride supplementation?
So you could probably just get, honestly, just giving the patient some fluids, right? So you can just give them some normal saline, even though we tell you a lot, in our other lectures to avoid some normal saline, but in this patient, you've got actually a low chloride level. And so one of the ways that you can increase that is just giving the patient some fluids. They have some GI loss, so they probably need a little bit of fluids. Maybe you're on the dehydrated side anyway to begin with. Good questions. Perfect. Okay. So case number 3, we've got a 19-year-old female who has diabetes. Okay, so then group number 20 in Augusta. Can you do steps 1 through 3?
No.
The pH is low, so that's acidosis. The PCO2 is.
I think you're cut.
The pH.
I think your mic is heading in and out, and so we're only getting every little bit and piece.
The pH is acidosis, the PCO2 is alkalosis, and the HCO3 is acidosis.
Okay. All right, and then group number 6. Can you do 4, 5, and 6?
So the PCO2 moves in the opposite direction, so that would be respiratory alkalosis, and the bicarb moves in the same direction, which is metabolic acidosis. And then the anion gap is 22, and then the excess anion gap would be 18, so it's an underlying anion gap acidosis. Sorry, not anion gap acidosis.
Okay, all right. So then group number 24, how did you describe your acid-base disturbance? What did you think was the most likely primary cause, and then what treatment did you recommend?
We said that the most likely cause was diabetic ketoacidosis from the way the patient was presenting, and they are they have type 1 diabetes, and presented with a sweet smelling breath. So we recommended treating the patient with insulin and fluids and stabilizing them.
Okay, and how did you describe your acid-base disturbance?
I'm sorry. We said that the primary disturbance was metabolic acidosis, and there was a compensatory mechanism of respiratory alkalosis going on.
Okay. Did anyone describe their acid-base disturbance a little different, or the same? Okay. So just a quick comment here. So anytime you have a primary metabolic acidosis, you have to describe that as being a GAP or a non-GAP acidosis. So let's talk about a couple of things that are new in this case. So I agree. So just let's move through all our steps to make sure we're on the same page. So step 1, your pH was 7.12, which is less than 7.35, so that's an acidosis. Your PCO2 from your ABG was 28, so that's a respiratory alkalosis. Your bicarb from your ABG was 12, and so that indicates a metabolic acidosis. And then when you were looking at both of those, your bicarb moved in the same direction as your pH, and your PCO2 moved in the opposite direction. Your anion gap, I agree, calculated at 22, so that indicates an anion gap is present. And then because you had an anion gap, you looked to see if there was an excess anion gap, which came out to be 18, which is a non-gap metabolic acidosis. Okay, so a couple of different things here. So how I would describe this acid-base disturbance is I would say that you have a primary anion gap metabolic acidosis with a respiratory alkalosis compensation. So when you're looking in step number 5, looking for if an anion gap is present, so what number did I tell you would indicate that no matter what anything else on any of your other values say, you will have a primary anion gap metabolic acidosis present? 20, right? Okay, good. All right, so when you're looking at step number 5, you're always wanting to calculate if you have an anion gap. If you have a metabolic acidosis that's present, you're looking to see if you have a gap or not. You can have a gap present, even at values obviously less than 20, right? You can calculate that and it'll be less than 20. But what you're looking for, and why that number of 20 is a little bit more important, is that when your anion gap is large, and so we use 20 as sort of our marker for that. So if your anion gap is greater than 20, then that is an anion gap that your body is unable to compensate for on its own. So that is indicating that's more of an emergency type situation. It requires intervention every time, end of story, no matter what any of your other numbers show. If your pH is normal and you have an anion gap of greater than 20, then you know you have an anion gap metabolic acidosis present, even if your acid-base status looks normal. Does that make sense? So you have to intervene and you have to treat there. So similarly is true on step number 6. When you're looking for an excess anion gap, that's telling you if you have a gap that's, so really, I agree with you when you're looking at that value. If it's less than about 23, then you have an underlying non-anion gap metabolic acidosis. But really what you're looking for, really what I want you to pay attention here is that threshold of 30. Because if that threshold is greater than 30 in your excess anion gap, so you're kind of moving in the other direction. You have a gap that's so large, a metabolic alkalosis that's present, that your body is not going to be able to compensate for that on its own either. So that also requires intervention on your part as well. So in this case, even though you have an anion gap metabolic acidosis present, your excess anion gap may also tell you may have some sort of non-gap metabolic acidosis that's happening too. But really, probably that number is coming from the fact that your anion gap acidosis is so large. So really what's important here is that you're recognizing that you have a primary anti-gap metabolic acidosis, like you all correctly identified for this patient who's in DKA, that needs intervention. Does that make sense? Everyone's on the same page? The other thing that sorry, go ahead.
How did you calculate the excess anion gap?
What group did that for me? Somebody, tell me how, one of the groups, tell me what numbers do you use to calculate the excess anion gap? Because this also came from the quiz. Also. So you take your anion gap, right, so we said that was 22, right? And then you subtract a normal anion gap value, right? And what number did you use? 12. Why did you use 12? Because I told you to, right? So there is a range, just like any value, right? So your range can start at 9, it can go a little bit higher than 12, it really depends on what lab you're using. But I told you guys to use 12 because in order to make the calculations and help us all be on the same page, we all need to sort of be using the same numbers. So for this class and for the purposes of an exam, use the number 12 so that you're all on the same page. Recognizing that when you're in practice, there's a range. And depending on what lab you use and what reagent you use, that number may be plus or minus a couple on either side. But just for the purposes of this, so that we all can be on the same page, use 12 there. So then that, you should have got, if you did 22 minus 12 is 10, and then you add that back to 8, because that's the CO2 value found on your chemistry panel, and you should have got 18 there. Is that good?
Yes.
Okay, so I did. Sorry. So I did just want to clarify. So I think I got confused because I think in the slide when you're calculating the excess, it said use bicarb, but we need to use CO2, the venous CO2.
Yeah. Remember, so everything with anion gap is CO2 from the venous, from the chemistry. Perfect. Okay. Yes. Great. The other thing I want to point out to you that is just something I want you to think about. So we talked about giving people sodium bicarb, right, for acid-base disturbances, and we've talked about it in other lectures, right? There's different thresholds. So this patient has DKA. So you guys have learned DKA yet, or no? You have? Yeah. Okay. Thought so. So when you have that lecture and in practice, we allow for much lower pH values, very, very, even sometimes less than 7. In patients with DKA before we would even give bicarb, right? I've talked about that before, where bicarb really doesn't do anything. It's never been shown to change anyone or improve anyone's clinical outcomes or mortality rates, but it does kind of buy you some time. So for the point of this lecture, if their pH is greater than 7.2, then you should not consider to give that patient bicarb. So that's pretty standard in practice in general, is if your pH is greater than 7.2, then you shouldn't think about giving the patient bicarb. If the pH is less than 7.2, then you can consider giving the patient sodium bicarb. So even though in practice and what you learned in DKA, you probably wouldn't give this patient bicarb, when we get to some other cases that are not DKA, patients who have a pretty significant acidosis, you can have a consideration for potentially giving this patient some small doses or a bolus dose of sodium bicarb to help you buy some time to allow your other therapies like insulin and fluids maybe potentially to kick in. Good? Question? Go ahead.
Okay, so did you classify this patient as primary anion gap metabolic acidosis?
Yes.
Okay, and if the excess anion gap was greater than 20, what would you classify them as?
Greater than 30.
Greater than 30.
If it was greater than 30, you would also have a primary metabolic alkalosis present. So just because you may be thinking something is primary is that it can only be one, you can have more than one primary condition. Really, that's just signifying that that is something, that there is a large change away from normal that requires your intervention. Okay? All right, good. So let's go to case 4 and talk about this. And you'll see, and as we get through some of these other examples, I have some other examples of how these look, where they may interplay with each other. Okay, so case number 4, we've got a 65-year-old male that's in the hospital recovering from his hip surgery, and he has some pain issues. So group number 14, can you do steps 1 through 3?
The pH is 7.28, so that is acidosis. The PCO2 is 52, so that's respiratory acidosis. and the HCO3 is 28, so that's metabolic alkalosis.
Okay, great. Group number 11. Can you do 4, 5, and 6?
Based on the information we have, so we said that the patient has a primary respiratory acidosis with metabolic alkalosis compensatory. The anti-gap is normal at about 7, and so we didn't have to calculate excess and gap.
Okay, all right. And then group number 23 in Albany. Can you describe acidosis disturbance and tell me if you agree with David, what you think the most likely cause is, and what treatment you would recommend?
So the patient has a primary respiratory alkalosis, or acidosis, I'm sorry, with metabolic alkalosis compensating. We think the primary cause is probably the IV morphine, and to treat, we can discontinue that IV morphine, and I guess would we give naloxone because we want to reverse the effects?
That sounds like a reasonable thought to me. Okay, good. So I would definitely think if you thought that was the cause and your patient was apneic and not breathing, then I would definitely consider giving that patient naloxone, or if they'd received any opiate, to try to reverse that. Okay, perfect. All right, so let's just, I agree with everything that you guys have said. So in step number 1, you have an acidosis because your pH is 7.28. When you're looking in step 2, your PCO2 from your ABG is 52, and it's greater than 45, so that indicates you have a respiratory acidosis that's present. And then in step 3, your bicarb from your ABG was 28, and that's greater than 26, so you have a metabolic alkalosis compensatory mechanism. You agree that I also got an anion gap of 7, so you have no gap present, so you didn't need to do step number 6. So agree, I would describe this as a primary respiratory acidosis with a metabolic alkalosis compensation. This most likely caused from a medication error, right? So it looks like they gave an oral dose of morphine as an IV dose, which caused the patient to have respiratory depression, which resulted in the respiratory acidosis. Again, the patient's acidotic, but the pH is greater than 7.2, so no bicarb here, so I agree with what you said. So giving the patient naloxone to reverse the effects of your morphine and hopefully bring up your patient's respiratory rate and fix his acid-base disturbance. Is everyone good here? Okay. All right, so let's do, maybe if you guys can take 10 minutes, and I'll check in with you and do cases 5 and 6.
What? You like pH?
When she keeps asking like to compare the PCO2 and the bicarb to the pH one?
Yeah, so like if the
Are you
bicarb,
comparing it to the pH?
like it, not like it goes down or up, because each like so if bicarb goes down, then pH goes down. So if it's acidic pH, then it goes in the same direction. But the bicarb goes up, so you just do the pH direction for each molecule.
And I mean, worst case scenario, what is I'm probably gonna fail it because I said I took a 3-hour hour and gave myself another pep talk. Yeah. And then if you go to the next slide, it's pretty much 30. So it's both. Well, no, it's both. I don't know if there's like one there in between or the both the primary, right?
So basically, everything is out. Like, didn't explain how to do it properly. And I was like,
It's not
I'm like, sorry.
It's just the. Yeah. Okay, so if you use your yeah, so if you're so like so dependent on your yeah. So it's greater than so regardless of what this if it's greater than 20, then we have to do like this. And you have to look at
So this one right here is what's most likely cause. Would it be alkalosis or acidosis? Because like if it says like if your anion gap is over 20, it's a metabolic acidosis. But then when you calculate your excess anion gap, if it's over 30, then it's a metabolic alkalosis.
I think that's what she was saying, that like there can be more than one cause. Like there could be like two things going on at the same time. But I don't understand how.
Metabolic alkalosis and an acidosis.
That's what I don't understand. Like how can you be both at the same time?
I figured he was acidotic because he has uremic.
Right.
So it makes more sense.
Oh my God. They're doing it on purpose. Oh my God.
I mean, he's got heart problems.
I was gonna do that. My primary problem was that he's actively bleeding.
Is he actively
I didn't even see that.
He
He is.
Where?
I mean, his growth hormone time was increased, his INR was increased, he was like throwing up blood.
But they said that had stopped.
But his INR and stuff is still
But I
like,
think, yeah, like if
he needs to
it
not be on
should've-
the list is the main thing. Like,
yeah.
Not turning on.
And on top of that, he's on clopidogrel and on aspirin. He's on like bajillion blood thinners.
I couldn't decide if he was actively bleeding.
I think there's still like some internal bleeding going on. There has to be. Like his labs are all out of whack.
Or it's, I mean, they're coming back up, but you don't want to keep them on an anticoagulant when they're not normal.
And then after that, I just kind of stopped because I was like, there's just too much going on with this person.
Is he supposed to have a beta blocker if he's in cardiogenic shock? Like,
They held all the blood pressure meds.
Yeah, I thought they had metformin.
Yeah, and I'm like, what the frick? I don't know.
Is he on
Malapropil is the AKI.
Huh?
Malapropil is the AKI.
Yeah, they started with both his. Are you on Metoprolol? As part of that, like,
He needs the suction.
yeah. I mean, but like, I haven't done any of my problems just because the only thing I'm just like.
This week always doesn't count.
He's not on diabetes meds, but it's got diabetes for 2 years.
But like, we have no lab values to even know if he's like diabetic.
Well,
We have no A1C.
on the,
like,
like, the glucoses were like
nice.
98, but on the notes it said, or like when they gave the insulin doses, it said blood sugar checkup was 196, so it's,
1 unit of insulin.
And I was like, is 1 unit really gonna help him that much? One singular unit.
Yeah. Yeah, he's not. I literally wrote diabetes in I was like, we don't have a single A1C value.
he doesn't have an indication for those
Those
overall.
all up either, yeah.
And I guess if he stays on like triple anticoagulation, it does have an indication for the long-term PPI.
For the time being though, I switched it to the H2RA because of Nashville's.
Because what?
Nashville's, because he had a STEMI like a week and a half ago. So I did H2RA instead.
Yeah, I forgot about that. You
And
can
then I
do
was-
either or, but the H2R is recommended, right?
No, there's no like good evidence for like either, yeah. It's kind of just like up to.
I think it's just because like H2Rs have less long-term stuff.
Like less benefit?
But I think if you're on triple anticoagulation, you should do the more potent one because that matters. Like,
And then I didn't know if all PPIs were an issue with
and we're
clopidogrel.
over diuresing him. Like his output were like 600 and his input was like 200.
He's on good for experience for a while.
Yeah, and his blood pressure goes down whenever they give him
Well,
clopidogrel.
he's on the spironolactone.
I think they put him on that because of his ejection fraction. It was like 15 or something.
Okay.
I don't know, basically.
Instead
Courtney
of
said that
giving
Dr.
him
Blaine
like
told her that this is like the most complex case.
How's everything doing? Need a couple more minutes? Or you good?
This is complex.
He's like, so if you're struggling, it's okay. And I'm like,
Yeah, I fiddled one this morning.
Does anyone need a couple more minutes? You can just wave if you do. Okay, it looks like everyone's ready to start discussing. Okay, so for case number 5, we have a 48-year-old male who's admitted with severe vomiting for several days, then he wasn't feeling very good, so he's missed some of his hemodialysis sessions because of his illness. So, group number 13. Can you do steps 1, 2, and 3? Okay. All right. Group number 18. Can you do 4, 5, and 6? Okay, all right, perfect. Did everyone get those same numbers? Okay, all right, good. Okay, so let's see. wants to describe this acid-base disturbance? How about group number 26 in Savannah?
We said there's a metabolic acidosis going on because the anion gap is greater than 20, so it's that regardless of the pH value.
Okay. All right. Group number 5. How did you describe the acid-base disturbance?
We agreed with the other group because we did calculate the excess to be 36 also, but because the original anion gap was greater than 20, then we said primary metabolic acidosis.
Okay. And both of your groups, what did you determine was the most likely cause, and then how did you treat it?
Group 5 said maybe it's uremia due to the missed dialysis session, and we would want to dialyze the patient.
Okay. Group 26, did you guys agree with that or have anything else?
Yeah, we also said do hemodialysis. We also noted that there could also be a metabolic alkalosis going on because the excess anion gap was greater than 30, but we didn't know if that was also occurring with the metabolic acidosis at the same time.
Okay. Did any other groups have described anything any differently or have anything different there? How many of you did not know how to describe this acid-base disturbance? Okay. All right, that's fair. Okay. All right, so let's go through these things and look at this. So I agree. So steps 1 through 4 were all normal, right? All of your values are in the normal range. And then when you got to step 5, I agree with, I think our Augusta group, you said their anion gap was 24, and then you had an excess anion gap that was calculated at 36, correct? Yes. Okay. So when I told you guys that if your anion gap calculation was greater than 20, then what did I say? Right, so you have a primary anion gap metabolic acidosis present, right? So why is your pH normal?
Is it because you also have an underlying metabolic alkalosis because he's been vomiting so much?
Right. Okay. So you have to have something else there, right? Because what if you stopped? If you were looking at this patient's lab values and trying to evaluate their acid-base status, and you stopped at step 4, everything looks fine. You think your patient is totally fine, right? That's why no matter what you see, you have to continue on with steps 5 and 6, right? So how I would describe this and what's happening in this patient is they have a normal pH. All of their values are normal because you have 2 large acid-base disturbances that are both primary and they're both interacting with each other. So they're not compensating for each other. There's 2 different disease states and mechanisms that are happening that are both affecting the lab values overall because they're both primary. Okay? So I would describe this as normal pH due to a competing underlying primary anion gap metabolic acidosis. Remember, so if you have a metabolic acidosis that's present, you have to describe that for me as being an anion gap or non-anion gap. And then you also have a primary metabolic alkalosis that's also present. So what likely happened in this patient is they've been vomiting pretty severely, it sounds like, for several days. They didn't feel good, so you can imagine that if it's time for him to go somewhere for his hemodialysis session, he may not have felt well, didn't go to hemodialysis, and then you had a uremia that developed. So you have severe vomiting causing your metabolic alkalosis, and then you have a patient who's now uremic from having missed hemodialysis that's caused an anion gap metabolic acidosis, and it makes all of your numbers look normal on the surface. Does that make sense? Okay. So in terms of treating, you definitely wouldn't give this patient bicarb. So when you're looking at especially your metabolic acidosis patients, and you're thinking about giving this patient bicarb, you wouldn't, right, because their pH is normal. So you just treat your underlying causes. So try to treat this patient's vomiting and get him dialyzed, and then all these things should correct. Is that good? Okay. So you can see an example here of how you have mixed disturbances that can make your numbers on the surface look normal. Okay? All right. So let's look at case number 6. Oops. Okay? So group number 1. Can you do steps 1 through 3, we've got the 28-year-old female who's in the ER with, it looks like she's got a history of kidney stones and has pain on urination.
We said the pH, they're in acidosis, and then the CO2 there in respiratory alkalosis, and the bicarb is metabolic acidosis.
Okay. And then group number 17. Can you do 4, 5, and 6?
I don't want to do it.
My mic doesn't work.
I still don't want to do it.
Vincent, you got it. Vincent's not
Come
here.
here.
What is it? What is this number? What? Number 6?
4, 5, and 6.
4, 5, and 6.
So this is for number 6.
Yes.
So we said for number 4, the pH and the bicarb are going in the same direction. The CO2 is the opposite. The anion gap is 5, and we didn't calculate an excess anion gap. Is that all?
Did you hear it? Maybe.
Say, did you hear that?
Can you hear us?
Do we have anyone from group number 17?
Can you hear us?
Oh, no.
Oh. Okay, we answered on one mic. I guess it's not working.
I'm sorry.
So for number 4, we said the pH and the bicarb are going in the same direction, and the CO2 is opposite. For number 5, the anion gap we calculated was 5, and then for 6, we didn't calculate an excess.
Okay, great. Thank you. And then group number 10. Can you describe the disturbance, what you think the cause is, and what treatment you would recommend?
For the acid-base disturbance, we described it as a primary non-anion gap, metabolic acidosis with compensatory respiratory alkalosis. We think the cause is a UTI based on the fused CARS acronym. And we would recommend dialysis to aid in removing the kidney stones to help with the UTI treatment.
Okay. Okay. All right. So I agree with most all of that. Okay. So in case number 6, your pH was 7.3, which shows an acidosis. Your PCO2 is 32, which is showing a respiratory alkalosis. Your bicarb from the ABG was 16, which shows a metabolic acidosis. And then in step 4, your bicarb moves in the same direction as your pH, and the PCO2 is moving in the opposite direction. And then I agree, your anion gap calculated at 5, so there's no gap, and then you didn't need to do number 6. So also agree with your description was perfect. So your most likely cause is probably, and not, I mean, you would not see something like this on the exam. So what acronym did you use? Did you tell me? Maybe said, oh yeah, fused CARS. Okay, good. So fused CARS helps you remember your reasons for a non-gap acidosis, and MedPals helps you remember the things that can cause an anion gap metabolic acidosis. So try to keep those in mind. So the most likely cause is probably a renal tubular acidosis from maybe a kidney stone. So maybe not necessarily urinary tract infection unless your kidney stone may be infected, which can happen. And then the treatment-wise, so hemodialysis, I mean, you guys probably don't know this yet. So hemodialysis is really just like a filtration mechanism for the blood. So there's really not a way through hemodialysis to remove a kidney stone. So depending on how large it was and if there were more than one, you would probably just wait and let the kidney stone pass on its own with no intervention, or they can do like lithotripsy where they can go in and try to actually like break up the kidney stone and make it smaller so it's easier to pass. But I mean, that is not important for today's class. Okay, good. So is everyone good with case number 6? Everyone on the same page? We're good? Other campuses? Okay. All right. So take about maybe 10 minutes and I'll check in with you with cases 7 and 8. And then we'll talk about those.
Can we be done?
So I'll check in about 10:40. So maybe give you 12 minutes.
12. Really only need 2. same thing. Switch them. I believe you. You don't have to do it. Can you charge from either one? There's two of the same ports right here. Can you charge from any one? Wow. Are they USB? Was the last one USB-B?
I don't know.
That.
What do you do with that touch thing up there?
You can do a lot of stuff. This is where I have my brightness thing and my sound thing. And then let me turn that back down a little. And I can take screenshots and I can pick where I want it to save to. And I can hit capture up here somewhere, I think. And I can do all my emojis up here.
That's nice.
That's what I most commonly use it for.
If I'm texting someone on my computer and I need to use emojis, I just switch to my phone.
Yeah. So I always use that, and I can lock my computer. What?
Pretty cool. Yeah, it is.
And I wanted the four USB ports.
Wait, why do you need 4 USB ports?
I have a few more than.
You know what I really want?
No point, but
I really want this nice little MacBook Pro, or the Mac Pro. Like
Mac Pro?
The Mac Pro. Yeah.
Why?
I don't know, I just wanted to sit in my house so I can look at it.
I have the
Yeah, you have like the Mac and like the one you don't use.
Yeah. The iMac. It's not the Pro though. The Pro is nice.
Yeah, the Pro is just like it's just so beautiful. Like that one, it's like a statement piece.
Yeah. And like the touch bar change uses based on what app you're in. Like if I'm in Outlook, I can delete things and flag things with this.
I think it's like a lot more expensive to get that touch bar.
When I'm on the internet, I can change tabs with it and open new tabs.
Oh wait, can you get that on there?
No, it just comes with a little touch ID right here.
I like the keyboard though. On yours?
It took a while to like get used to, but it's
different. Yeah, it's like my keys are like flatter.
I think they're a little louder than like normal keys, but I like it because it's like a duller sound. Like it's not click feed. It's like a thud kind of.
I tried to type on your laptop, but I can't get used to it.
It took me a while. I was like making so many typos at first because like it like felt weird on my fingers. But it's
Double that.
1,400.
Why you get another computer?
Because this one's gonna break.
How do you know?
It's not supported. It's not supported anymore, and it's gonna like I can't update it anymore, and it's getting slow, and I just don't want it to crash and like me lose everything.
Back it up. Yeah.
But then if it crashes, I
Or a
still
hard
have to
drive.
go get a new computer.
Yes, but just in case it doesn't crash, you don't have to blow $1,500 if you don't have to. Get a $20 terabyte hard drive and back it up to it.
When my phone crashes and I have to go get a new phone, it's the worst thing in the world. So I'm just really trying to prevent it with.
That's an excuse so you can go spend $1,500 and have a statement piece. You know it.
No, this one's not the statement piece. This one's like, I just need I need a new laptop because this one's not supported anymore.
Don't get the like MacBook, no ports.
Yeah, I'm not getting that one. I'm getting the 13-inch, MacBook Air, like the one with the most memory. It's like, yeah, it comes to like $1,400.
Yeah, I got the 256.
Yeah, that's the one I'm getting.
The space.
Yeah, well, that would be that same computer.
If you
The $50
yeah,
off.
you can get $50 off your
You might be able to get headphones with it.
I don't want headphones. I'd rather them just like give me more of a discount. You know?
Well, they won't do that. I think they
I
do
know,
that.
right?
If you don't want the headphones.
Okay.
How many pairs of headphones do you have?
I have a bunch, but I don't like any of them. It's just one Bluetooth headphones or my
What kind of
AirPods.
headphones do you have?
Get AirPods.
They're expensive as fuck.
They were on sale for. I got mine
think that
for.
the sound quality is good enough for me to spend whatever dollars on my AirPods.
Wait for AirPods too.
Well, I have like Bose headphones, and they sound way better than those.
But still, the
Yeah, those
price of the
have-
original
I
AirPods
like
won't
how some
even
of
drop
those-
that much.
I just want
At
Bluetooth
all.
ones.
Yeah.
Bluetooth
Yeah.
Bose headphones are
It's
like
so annoying.
$400.
Because
I have some.
I wanted an Apple Pencil for my iPad.
Blake. Oh, I guess Blake.
Oh,
You probably
the new
have
pencil's gonna come out. Well, the old pencil still cost $100.
There's some that are like completely wireless.
Looks like
And
you
the
just
new one
gotta
is $130.
Looks like you just gotta get the new pencil.
He has some that plug in.
The new
right
pencil
now.
charges by itself.
The new pencil isn't compatible with my iPad. So then
Time
I
to
would
get
have
an
to
whole
buy
new
a
iPad. New iPad that just go all out, ball out.
My Pro is literally one generation older than like the Pro that's out right now, but of course it's only compatible with the old pencil.
That's a real bummer having to charge it by plugging it in like that.
I know.
It
The-
charges so fast though.
The magnetic charging is so like
I know, it's so
that's
cool.
Oh yeah, there's like some on here that are.
I was thinking about selling one.
These are pretty
like 6
These
months
are
old.
do it.
the ones
pencil?
I have. I got the Sound Sport.
I was like, I'll swap a pencil.
And they sound really good.
I already have an iPad, but I should need a
Aaron,
pencil.
are you listening?
What?
Okay. Well, the ones I got are those like Sound Sport ones, and they sound really good.
I like those
These?
that like wrap around your head
Yeah.
so they don't, and like stick in your ear so they don't
But
fall out.
they had these too. Those are like the ones that are completely wireless, but they're like this thick. Like when you put them in your ears, they're like.
Are you talking about the Bose wireless ones?
Yeah, these are the ones I have, and I really like them. And they're still kind of thick. Like I feel like they stick out of my ear like this much. But they sound amazing.
I miss my
How long
AirPods.
do they last?
It's like 6 hours.
They slipped out of my
No,
scrub pockets
they're
on the bus.
I was looking at these.
Oh
and then
my god, I would cry for days.
I was actually sad for about a whole month. I called the lost and found at the bus literally every day for 2 weeks.
Well, obviously someone
They're-
stole
Yeah,
it.
well, yeah, for sure. But
Wow, what an asshole. That's so sad. Oh gosh.
like, I got off the bus, realized that I didn't have them, and skipped class to find the bus. And then, like, by the time, because it was a north-south bus, and
Did you find the bus?
yeah, and it was already gone. Like it was a north-south bus that was coming from Tate back to pharmacy school, right? I got off at Snelling, and then north-south only goes like 3 stops that way, and then comes back, right? And so I waited for it. As it came back, I got on. I found the same bus driver. Nothing. So like in the 3 stops, someone stole it.
These have a longer battery life. These last 8 hours.
I know.
They're like slimmer.
And I just
That
can't
might
justify.
be for me. I would do that.
I just can't justify buying AirPods again because I'm just like, what if I lose them again? So I'm gonna just wait till AirPods 2 come out and I'll buy them. I'll be like, hey, it's the new one. It's okay.
Yeah, you're like, ah, it's fine. I'll spend
Yeah.
Like as long as they're like sweatproof, I'm good.
But they're new.
You say you lost your headphones on us?
My AirPods on the bus.
That really
If I would,
sucks. Do they not have like a Find My AirPods app?
Find My AirPods is strictly through Bluetooth. The AirPods themselves don't have like a GPS locator like your phone does, or
That
your.
does absolutely no good.
It's literally just Bluetooth. So it tells you the last place that your phone connected via Bluetooth to the AirPods, which was the bus stop at Tate. So like it just says Vincent's AirPods at the bus stop at Tate. I was like, oh wow, thanks. That really helps me out.
put on every north-south bus. and just start pretend.
I also never wear those scrubs anymore unless like I really like don't have scrubs to wear because every time I see the scrubs I'm just like
Best Buy will let me.
ah,
It's just a reminder.
yeah, that's it's just as a reminder.
I got them on like the holiday return policy, so like everything bought from like the end of October through Christmas. You can return until January 31st, and I'm getting real close, but I really want to compare. But I don't know if they'll let me take it back. I need to just ask.
You might be able to take it back normal time, can't you?
You can only return things. Best Buy has the worst return policy.
After you open it,
Really?
you return it?
You can only return things for 14 days. That is so dumb.
So wait, what are you trying to buy?
We were like talking about wireless headphones,
Mhm.
and there's a Bose pair that I bought, and then there's also another one called Jaybirds, and they're like the best. Like those two are the best.
I heard about the
voice.
Jaybirds, but the Jaybirds, I feel like the Jaybirds are like more athletic focused than the Bose.
The Bose ones, I was telling him, like, the only thing that the Bose ones outperform the Jaybirds on is the sound quality. Like, the Bose ones obviously have better sound quality, but, like, the Jaybirds last longer, and I think, like, in their app, you can, like, adjust things how you want, which I don't really know how to do that, so
I feel like that's why I just would prefer AirPods, because I'm not a huge audiophile. I just need, like,
well, see,
the convenience
I like
factor.
to have them because I'm like running and stuff, but like the Jaybirds last longer and they're smaller, which I like, and I think you can like put them in water deeper than you put the Bose ones. It doesn't really matter.
So I feel like
it's like you can only like submerge the Bose one for like 1 meter.
I don't understand, like, why are you trying to listen to music when you're jumping off like a tower?
So it's like I'm like as long as they can take like sweat.
It's gonna all like they're gonna rip out of your ears when you hit the water.
You're gonna have to go diving for your headphones.
Yeah. All right. How is everyone doing? Anyone need more time? Other campuses? Do you guys need any more time? Are you good?
Maybe I'll just start a chat and ask them if I'm allowed to.
Okay. It looks like most groups look like they're ready. Okay, so case number 7. We've got a 32-year-old male with a history of bipolar disorder and multiple suicide attempts who's found unresponsive, has several empty medication bottles around him. So group number 2. Can y'all do steps 1, 2, and 3?
Alright, so for the pH, it's less than 7.3, so we said it was acidosis. For the PCO2, we said respiratory acidosis. And then for the bicarbonate, we said metabolic acidosis.
Okay, good. All right, and then group number 12, can you do 4, 5, and 6?
It looks like we've got a mixed acid-base disorder with an anion gap of 22 and the excess anion gap of 26.
Okay, all right. And then, let's see, group number 16, can you describe the acid-base disturbance, what you think the cause is, and what treatment you recommend?
It was all pump and
What?
you all pump no dump, isn't it? What? What? What do you mean all pump? Are you all pump no dump?
Yes. How'd you guess?
The
Kendall
picture.
told me.
Okay, all right. And group number 15, did you also describe the acid-base disturbance the same way?
We had primary agno with a mixed disturbance occurring since they were all going in the same direction as the pH.
Okay, all right. Did anybody else have describe it any different way or have anything else different? Okay, all right, so let's go through the different steps. So so step 1, your pH agree 7.05 shows an acidosis. Your PCO2 from your ABG is 55, which is a respiratory acidosis. In step 3, your bicarb from the ABG was 14, which is a metabolic acidosis. So in step 4, when you're comparing those two values, they were both moving in the same direction as your pH, right? Your anion gap, I also got was 22, which shows an anion gap is present. And then your excess anion gap calculated at 26. So I just wrote this as no excess gap is present because they're not greater than 30, even though that there is a value there. So how I would describe this acid-base disturbance. So you guys are all right. So you definitely have a mixed disturbance, right? You have a mixed respiratory and an anion gap metabolic acidosis with no compensation occurring. Agree? Does everyone agree with that? So I would say your metabolic is probably most likely your primary, since they all went in the same direction. So remember in step 4 that also helps you determine what your primary cause is. So you've got both things that are moving in your same direction. And so I would probably say, even though this may not be as important in this case, since everything's moving in the same direction, but your metabolic, because your anion gap is so large, is most likely your primary disorder here. And that makes sense because I agree with you guys. So you have a salicylate overdose, right? Remember, is one of your mud piles. That led to potentially an obtunded state where the patient was not breathing, so they, knocked out their respiratory drive to try to compensate for that as well. So then that's probably why you have everything that's moving in the same direction. Does that make sense? Okay. So treatment here, I agree with you. So your pH is less than 7.2. So definitely consider giving bicarb. We'll probably give this patient bicarb initially, and then also consider intubating this patient, and then hook them up for hemodialysis potentially to increase that toxin removal as well. Everyone good with case number 7?
What about acetylcysteine for all the Tylenol they took?
Okay, so you potentially can treat. So the patient potentially has a overdose or a toxic situation with acetaminophen as well. Most of the time, acetaminophen overdose affects your liver primarily and doesn't necessarily, until it's pretty advanced, affect your acid-base status necessarily. In this case, if the patient had an elevated Tylenol level as well, you are correct, and we would most likely give this patient acetylcysteine as well to try to facilitate and help to decrease potential liver damage that may be occurring from that also. So that's true. I just put that separate to focus on the acid-base stuff, but you're correct as well. Good. Okay, so case number 8. So this one has a lot going on, right? So you've got your 22-year-old female who's coming to your hospital with multiple things that are happening. So group number, who have left? Group number 22. Can you do steps 1, 2, and 3?
The pH is alkalotic. The CO2 leads to respiratory alkalosis, and then metabolic acidosis is the compensatory.
Okay. And then group number 4, can you do steps 4, 5, and 6?
We said the PCO2 and pH move in the same direction, bicarb and pH move in opposite directions, and anion gap of 30 and excess anion gap of 32.
Okay. And then I think our last group that hasn't answered yet, group number 7, can you guys describe the acid-base disturbance, what you think the cause is, and what treatment do you recommend?
Since the anion gap is greater than 20, there's a primary metabolic acidosis, but since the excess anion gap is greater than 30, there's also an underlying metabolic alkalosis, with the cause being hyperglycemia and diabetic ketoacidosis, and the treatment being to replenish fluids and electrolytes and give insulin once they're stable.
Okay. All right, did anyone describe the acid base differently or have anything else to add? Who had trouble with this one? Okay, all right, let's look at it. Okay, so in step 1, your pH is 7.5, which shows an alkalosis. Your PCO2 from your ABG was 26, so that's a respiratory alkalosis. Your bicarb from your ABG was 16, which is showing a metabolic acidosis, right? Everyone's good there? Okay. So when you're looking at step 4, your PCO2, so that was moving, so that alkalosis, the respiratory alkalosis is moving in the same direction as your overall pH. And your bicarb was moving in the opposite direction. I agree with you. I got the same numbers you all did. So your anion gap was 30, which showed an anion gap was present, and your excess anion gap was also present with a value of 32 as well. So this is a triple acid-base disturbance. So you have 3 different things that are all coming into play with this patient. So this is the most complex acid-base disturbance you'll see, right? So you have a primary respiratory alkalosis, right, because that was in step 4, showed you that your alkalosis was moving in the same direction from your respiratory side, right? So you have a primary respiratory alkalosis because your PCO2 moved with your pH. You also have a primary anion gap metabolic acidosis present because your gap was greater than 20. And then you also have a primary metabolic alkalosis present because your excess anion gap was greater than 30. Does that make sense? So you have all 3 things going on. So your most likely causes, you guys have picked up on most of these things. So likely could be decay that's causing your anion gap metabolic acidosis. The patient had been vomiting for a significant amount of time, which could have caused her metabolic alkalosis. She also looks like she may have a pneumonia, and that may have affected her respiratory status and caused the respiratory alkalosis from that standpoint. So respiratory alkalosis, treatment-wise, is pretty self-limiting, so maybe it wouldn't do anything here necessarily, and then treat your underlying diabetic ketoacidosis and treat the patient's vomiting like you guys suggested, and that should correct. Is everyone good with case 8? Does that make sense? Feel better about that? So remember, just kind of to wrap things up at the end, so remember your kidneys are super complex. If you go back to all the things that you learned about kidneys, right? Kidneys can do lots of different things with filtering, excreting fluids, but also with electrolyte exchange and reabsorption. So your kidneys can do multiple things at the same time. So think about your lungs. So think about what your lungs can do. So do you think you could, so when in this patient you had a triple acid base, right, disturbance that was present. So if you had a patient, do you think you could have a patient that has a respiratory alkalosis and a respiratory acidosis at the same time? Like you had the metabolic, both were present in 2 of your cases. But could you have a respiratory one? Why not? Use your mic. Be brave.
I don't think you could have both because a lot of it's based on respiration rate and the rate that the CO2 is being released from the body.
Right, so lung-wise, is your respiratory status is all dependent on the rate of breathing and the depth of breathing, right? So lungs can really only go one direction, right? So that's why the changes happen fast, and they also don't last very long. So when you have these pretty significant disturbances, especially on the metabolic side, your lungs can actually only compensate for so long as well. So if you imagine if you need to breathe 45 times a minute to try to breathe off some of the CO2, your body can only do that for so long before it will knock out and you won't be able to breathe anymore. And so that's why sometimes, a lot of times you'll see patients who need mechanical ventilation to help with that. So in some of these cases, when you see these pretty significant metabolic disturbances, you'll also notice that they start to have their respiratory drive is completely knocked out as well. So just kind of keep that in mind when you're looking at really complex acid-base disorders, that you're really, triple is your most complex, but really your kidneys are very good at being able to adjust multiple things at multiple times, but your lungs can really only go in one direction and not for very long. Does anyone have any questions about any of the things that we talked about or any of the things? I feel like we, at some point during this time together, went over all the questions on the quiz, so hopefully everyone feels good about that now as well. And then if not, you guys can always email me, you know how to find me, if you have any questions. But other than that, that is all I have for you guys today.
Brandon, I have a question in Augusta about case number 3.
Okay.
So when we calculated the anion gap of 22, we got a primary anion gap metabolic acidosis. But then the excess anion gap of 18 makes it sound like since it's less than 23, there's an underlying non-anion gap metabolic acidosis.
Right. Right, so that's true. So the thing about that is really, the step 6, really what you're looking for is if you have that very large excess anion gap. When you have a pretty significant anion gap, metabolic acidosis, it's going to, because of the values being so much further away from normal, it's going to calculate things out and also make it look like you potentially, and you may, depending on your disease state, and when you look at how your patient presents and you look at your causes for non-GAP metabolic acidosis, you are likely to have some overlap there and have both things look present. But as long as your anion gap is greater than 20, the most important thing is that's primary and that's the one that needs intervention. As you resolve and intervene and fix that one, your non-GAP acidosis is also going to correct just by default, if that makes sense. So really with step number 6, the thing that is the most important is looking for that threshold of greater than 30 to see if you have a pretty significant metabolic alkalosis that's also present. Does that make sense?
So the anion gap metabolic acidosis kind of trumps anything about non-anion gap. You have to intervene for the anion gap.
Yes, especially when it's greater than 20.
Okay, thank you.
Yep, good question. All right, great. Thank you guys for your participation and attentiveness today. Have a great Friday and a great weekend.